Hanson. He's a senior VP. Good morning, everybody. Welcome back to the GuideWell Insights Lounge. This is Kate Warnock coming to you live on location at the 2017 AHIP Institute and Expo. I am delighted to bring back one of our favorite guests, Mr. Eric Grossman. Eric, welcome to the interview.
Thanks, Kate. Thanks for having me.
We've been able to talk to you for a couple years now, so I'm glad that we get to catch up again. So, Eric, your title, you are the President and CEO of Next Health Technologies. So, Eric, we were talking before the camera started. You know, we can talk about your services, or we can make your services a little bit more real. Give us an idea of how you help a patient with what you do at Next Health Technologies.
Good question. So if you first use an analogy, we all shop at Amazon.com, right? And you notice how it recommends people like you bought whatever for the Warnocks, right? Yeah. We borrow that same type of technology for healthcare, and it's actually quite complex what they recommend. They're looking at people like you bought, it was successful, and they follow you all around, and it actually generates more than half of their revenue, that add-on recommendation. So if you pivot to healthcare, for Florida Blue, we've partnered with GuideWell Connect to help your exchange members find more appropriate care settings instead of using the ER.
Okay.
So take a 64-year-old woman named Susan, whose husband is actually a retired physician. It turns out she's been using the ER about 6 times in the past 6 months for low acuity things like flu, spider bite, and GuideWell Connect reached out to Susan and got her on the phone. But before we got her on the phone, we knew she lives in a rural part of Florida. There's no urgent care near her, and we know she'd been going a lot. So we reach out to Susan, and this is a real member. We get her on the phone, and your CSR starts explaining that we offer this benefit for non-acute, non-severe interventions called a nurse advice line. She says, hold on a minute. I just want to communicate that my husband is a physician, retired, but he's a physician. So we're pretty familiar with the healthcare system.
Yeah.
Well, we obviously know she's been going to the ER at $1,800 a pop 6 times.
And no accounting for how much of her time she's been spending in those hospital settings, because they're not exactly,
right,
quickly, addressing her needs. So,
right.
Yeah.
And it costs everyone more money,
Absolutely.
Including her. So she instantly disclaimed the fact that she was aware of the healthcare system when we knew she wasn't.
Right.
So we get her on the phone, we tell her about this amazing nurse advice line that we offer, and then we're going to send her a refrigerator magnet she can put on her refrigerator. And it ends up moving from my doctor, my husband's a physician, to, that's great, that's why I buy Florida Blue. I didn't know about this benefit, and that refrigerator magnet's as handy as a pocket square, she said. So that's a good example of how we understood and delivered a personalized message to someone we knew that was going a lot for healthcare in the wrong setting of the industry.
So it sounds to me, Eric, so Next Health Technologies, you have predictive analytics capabilities, you work with your partners, and you're helping to really identify those individuals that are most in need of education and being better aware of their benefits to help both them and the health plan with that medical expense.
Exactly.
Right, okay, well, that's fantastic.
Great.
So, since we've spoken to you, I think we were last speaking with you, Eric, the end of last year. What's new in your relationship with GuideWell Connect? Anything new that we can watch coming down the pike?
Yeah, I think the most impressive thing for me is we're really good at analytics. GuideWell is really good at consumer engagement, and as we get really good at consumer engagement for Sarah, right, or Susan, the woman,
yeah,
it was actually low acuity situation. She'd be going for spider bites, but we're learning that in order to really get even more value out of the healthcare system, we need to intervene with the person going for diabetes that is completely preventable, but they're going to the ER. But it's harder to change their behavior. So in order to do that, GuideWell and Next Health are sort of coming out with V2. V2 is better integration with the providers that GuideWell already partners with, and more expensive interventions.
Okay.
So we can use the retail center, we can do video through GuideWell Connect. So we're really excited about investing more in complex nudges and interventions that involve the physician, more complex channels like video and text. So those things are coming down the pipe, but I think we've been really impressed on the low acuity interventions with GuideWell Connect's ability to get a hold of the members at upwards of 45%, where the industry is around 25%.
Yeah.
So that's double the effectiveness of most other companies that you might see at this event.
So, again, I think the value of what you bring to the table and the relationship with GuideWell Connect is you're really personalizing that care. You know so much about the individual, and you're there to really help them get the most for their healthcare dollar, which, as we know, so much more of the burden is going to be on that consumer. So you're really making sure that they get the optimal level of care in a really comprehensive and personalized way, because you're saying now you're going to offer video outreach and text and everything. So it sounds
right.
like you're doing that multi-pronged approach. That's an exciting development.
I would sort of put quotes around a word you use, get optimal care. That's probably the most unique aspect of our relationship. Is we actually scientifically determine if you did buy the product on Amazon, or you did go to urgent care instead of the ER. And it's that ability that really differentiates us in the market, because we can prove attribution that our intervention did truly move the needle.
Absolutely, and that's so key for anybody who would be looking to you. You can put that ROI right in front of any
Yeah, it's not just about that you clicked on the next best product.
Right.
It's what Amazon cares about is, did you buy?
Yeah.
And in our world is, did you change your behavior? So
Right.
it's not about gaps in care or click-throughs. It's about, did Sarah indeed use the lower cost care setting?
Perfect. All right.
We don't know yet. It's early on her.
Well, I think that little magnet, that's better than a pocket square. I'm certain she's.
I thought
she's
that was a
gonna
good
go.
comment,
That is
wasn't it?
that's
Better than a
you know,
pocket
better
square.
than a pocket square. All right. Well, Eric, we love having you here at the
Thank
GuideWell
you, Kate.
Insights Lounge, and we know that we're going to catch up with you again soon. So, listen, everyone, we're going to have another interview in just a minute. Please keep watching. This is Kate Warnock. We'll be back live in just a bit. Hi everyone, and we're back live here at the GuideWell Insights Lounge. This is Kate Warnock coming to you live on location from the 2017 AHIP Institute and Expo. Our next guest is Stuart Hanson. Stuart, welcome.
Thanks. So nice to be here, Kate.
We love having you here. So, Stuart, your title, you are the Senior Vice President and General Manager of Consumer Payment Solutions at Change Healthcare.
Yeah, sorry, that's a mouthful.
That's all right. That's a
Sorry.
big job, it sounds like. So let's get into an article that you recently published, Stuart. It was really interesting, and I know it's going to be the focus of your talk here at AHIP.
I think it is, yeah.
Yeah, so lots of folks have likely heard of patient engagement. Maybe not so much around financial engagement.
Right.
Tell us, why is that going to be the linchpin for health plans to really start embracing that notion?
Yeah, it's interesting, especially at the AHIP show where there's so much talk already about consumerism and just in general, the impact that that's having on plans and how they engage with their members. What's really important to know is that health plans are in a really unique position to develop a valuable solution for their members through financial engagement, right? How many times do you get an EOB and a bill and try to match those up before you make payments?
Sure.
71% of the time, consumers try to do that.
Yeah.
So they get frustrated that they get these EOBs and they can't make payments from them.
Yes.
Right, so that's a real point of frustration and angst for consumers. And because health plans are their central adjudication point, it's a natural extension of their member experience to engage with their members more financially.
Absolutely.
So they foster the trust with consumers that the amount they're being billed is correct, which is why they do that matching, and giving them an enhanced experience to be able to deeper engage around their financial experience in healthcare is a great way for health plans to leverage that.
So I think what you're talking about, just reduce that friction point.
Yeah, exactly.
Yeah, make it easier
simple.
and simple, and boy, that certainly is a theme that we're hearing about more and more. So
yeah, consumers want it, Amazon simple, right?
Absolutely. So let's pivot a little bit.
Sure.
I know that Change Healthcare just announced a really exciting partnerip with Hyperledger.
Yep.
Some folks might be familiar with it, maybe especially if they follow the financial tech sort of end of the world. But I was hoping if you could explain for us and our viewers,
Sure.
blockchain, this notion of blockchain, and that's really what Hyperledger is about. Break it down for us in layman's terms.
Yeah, I'll try to do my best.
All right.
I am a layman in blockchain, so
Okay.
it will be in my terms. How about that?
Sounds great.
But blockchain is really just a distributed ledger that evolves over time and accumulates all of the historical data related to a specific transaction.
Okay.
So it's an indelible mark. It's tamper resistant or very protected information regarding a historical transaction, and it's a constant log of all the activity against a certain transaction. So the nice thing about that is that it captures it's a great opportunity to capture a lot of detail associated with a claim transaction or a payment or a balance in an HSA account, and track that over time in an uneditable format, so that data carries with the transaction.
Isn't what's most unique about this is that it can be controlled by the consumer?
Yeah, again.
Right. Which is really, that's that power shift that we've been seeing. A lot more demand as consumerism rise, that people want more access and more control over their data.
Exactly right.
And you mentioned too, so it's more secure. Is it hack proof?
I mean, I don't know if anything's completely hack proof, right?
Yeah.
There's always more that can be done, but I think certainly that's one of the commitments that we're bringing to the Hyperledger consortium and partnership, is to make sure that the PHI, the information that's so sensitive in healthcare transactions, is properly protected as part of finding the right solutions to leverage that technology for healthcare.
I know that you said you're not an expert, so let me know if this is a little bit beyond your knowledge base, but I've heard blockchain being used as, the data security aspect of it, the interoperability of it, the fact that the individual can control it, but are there other solutions that might be competing with blockchain that might come to fruition more readily? Because
that's a good question.
Yeah, some folks are saying that blockchain really belongs to the financial tech side of the world, and it's not going to translate to healthcare.
Yeah, what's interesting is I see a logical connection, but I think the commitment right now is to try to innovate and try to find the right use cases to leverage something like blockchain. Are there other potential technologies that could enable those use cases? Probably in almost all cases, yes.
Okay.
But I think finding the best use case where blockchain is the most efficient technology to be able to use, or it's got enhanced security or enhanced information sharing or interoperability capabilities, that's where the gravity is going to go as the industry tries to figure out how to leverage that.
Well, it's going to be really exciting to see what comes with your partnership with Hyperledger.
I think it will too.
We'll
it's
be
really
watching
exciting.
that for sure, and I'm sure
thanks.
we'll see some more LinkedIn articles from you on it.
Absolutely.
Stuart. All right, one more
thanks.
question for
Sure.
you. So again, related to blockchain, what do you think it's going to take for it to move from promising solution to really getting traction? Tell us maybe what are some of the barriers that we're going to have to overcome for it to be viable in that healthcare setting?
I think it's too early to say exactly what the barriers are going to be. There's a lot of people concerning themselves over whether healthcare is going to fall behind, right, and have to catch up in blockchain in some ways. I don't think that's a real problem. No, I really don't. Because I think that the commitment of all the stakeholders that are going to build the right solutions for this to partner in places like Hyperledger is really going to foster the right speed of the right opportunities. If they find 8 different things that are super applicable to blockchain, I think the industry will move very quickly towards that.
Well, it sounds
if the value proposition's not there, then they won't.
Right. But the collaboration is key, isn't it?
It is.
Yeah.
It really
so
is.
Really exciting. I want to go back to our first question in that interview, or the article that I referenced. Where can folks find it, talking about this financial engagement?
Yeah, I think there's a bunch of stuff that we're publishing. A lot of it is available through our website, changehealthcare.com, but also LinkedIn. A lot of HFMA, I think, was the publisher of the article that you're referencing specifically. So, we're trying our best to get good information out there for our clients through a number of different channels.
Well, Stuart, that's why we wanted to have you here at the Insights Lounge, so that we thought that you just had a really interesting perspective and wanted to share that with folks, not just here at AHIP, but beyond. So
thanks a lot for having us.
Well, we loved having you. Thanks so much for joining us. So this is Kate Warnock. We're going to sign off for just a moment. We're going to get our next guest up. Please keep watching.
Thank you.
everyone. We're back live here in the GuideWell Insights Lounge. This is Kate Warnock coming to you on location from the 2017 AHIP Institute and Expo. Everyone, I am honored to have two guests with us right now. We have Dr. Eric Rifkin and Andy Lazarus. Gentlemen, welcome to the interview.
Thank you.
Great being here.
Well, we're so excited to have you. You have such an important message to share. So before we get started with questions, let's introduce who you are. So Eric is the Adjunct Associate Research Scientist with the School of Public Health at Johns Hopkins University. And Andy, you are the founder and medical director at Personal Physician Care. And you gentlemen, you have a personal relationship too, don't you? You know, you're Dr. Lazarus, you're actually Dr. Rifkin's primary care doctor, aren't you?
He's seen me only once, but yeah, but yes, that's as much as he's ever seen a doctor. So that's pretty good.
That must have been a really eventful visit.
It was an eventful visit.
Well, my wife beat on me for a year, and finally I decided to go ahead and do that.
That's terrific. All right, well, I'm so excited to talk to both of you. So, Dr. Rifkin, let's start with you. Can you give us a sense of the scale of overtreatment and its impact on the U.S. economy?
Yeah, that's a good question. Believe it or not, the Institute of Medicine has come up with a number of $750 billion in unnecessary treatment. And that has ramifications for the whole country, for what individuals do and how they spend their money and how their deductibles are paid and whether they can do other things as well. So if we can get rid of that problem, we can truly modify healthcare in a very positive way.
Absolutely. I mean, this is what we talk about when we say the current healthcare system is unsustainable. Overtreatment is really a primary cause of it, isn't it?
It is, and it's becoming more of a cause and a problem because most people now are having their deductibles raised, and they're finding it virtually impossible to get the coverage they need based on what they can afford.
Right, absolutely. So here, you know, at AHIP, that's such a predominant theme is talking about the individual consumer and how can they get the most for their healthcare dollars. So, you know, again, we're going to explore a little bit more about how you're going to help make that possible. So my next question for you is Dr. Lazarus. So again, in doing some research on your background, you know, you use this term called low value care. I was hoping that you could define what that means and what the connection to, and what is the connection to what care is incentivized. So what is the definition, and then tell me how it relates back to being incented.
Sure, and I'm a doctor who sees people every day, and I interact with the specialist community, the hospital community in my neighborhood. And what I see in terms of low value care is patients just thinking they need to do stuff. You know, stuff that they're told, you got to do this, you got to do this, you got to do that. You know, they go for an annual stress test, for instance.
Right.
Every year they think my doctor's really cares about me. But that's an example of low value care. We know from stress tests that if you get a stress test without symptoms, your outcome is going to be worse than if you had the stress test not at all.
Right.
And when we use our device to talk to patients, we can show them that. There are a lot of drugs that are low value care. If you look at someone, for instance, with dementia, and I take care of a lot of them, they get MRI tests regularly, they see neurologists regularly, they go on drugs for dementia regularly. None of that stuff has been shown to alter not only whether
their outcomes, right?
their outcome, but also their day-to-day life. Whereas exercise, socialization does, so
Right.
which are high value.
Right.
So our insurance system does not help them get exercise, does not help them get socialization. They can't go to a daycare center, but they can see the neurologist every 2 months. They can get MRIs, all that gets paid for. They can get drugs. The neurologist, when they give them the drugs, is doing something, so the patient says someone's helping them. When we tell them to do exercise, they say, well, that's a cop-out. So our system is completely incentivizing a lot of this low-value care, and it goes, you know, across the gamut. There was a study recently that showed that in a 10-year period, the cost of cardiac care alone, heart care, went up by $100 billion per year. And that $100 billion was based on doing stress tests and echocardiograms that we know are low value. And predictably, the outcomes over those 10 years were no better. So again, and they're getting paid very well to do those tests, and patients think they're being treated well when they get the test. So that's the low value care we talk about. And what I've found, when patients understand that care is low value, they're much less interested in getting that care. They're just led to believe by our entire medical society that these things are necessary.
All right, so let's pivot then. I think what it really gets down to is education, and you gentlemen have come up with this really fantastic tool, this decision aid, that's going to help people really understand the value of care versus maybe exercise over a drug or something. Let's talk some more about that.
Yeah, that's a good point. Decision aids have been around for a long time. Unfortunately, the response is they're around, but they really don't do any good, and nobody uses them. And that's probably because doctors don't want to be inconvenienced by using them, and probably because most of them aren't as effective as they should be. What we've done, which is different, is develop a decision aid that people can relate to specifically. It's a familiar theater. Everybody has been to a theater or a church or a synagogue or something else that requires a grouping.
Yes.
They can put themselves in it, and what we do is we blacken in the seats when there are benefits, and we blacken in the seats when there are risks, and they can counter one with the other so that they can make a determination based on their values and preferences whether they should have medical intervention or not. And the doctor helps them come to this conclusion, but it's not a scientific or medical decision. It's based on what a patient really believes, and we've found over the last few years that it's very effective, and that patients in fact do relate positively to it. And it's a very rewarding thing for us, because we think we're doing something meaningful by having patients benefit from it.
Well, what's amazing is when I first met Eric, he had written a book, and a friend of mine knew Eric, and Eric was giving a talk on his book. And I was a doctor who had been doing this for 15, 20 years, and what he told me blew me away. Because we in the medical community, doctors and patients, are very attached to something called relative values. So a certain intervention, taking a blood pressure medicine, will lower your risk of heart attack by 25%. And we say, wow, 25% is a lot. What Eric showed me is 25% could mean 1 out of 1,000. It really depends what the numbers are to begin with. And once he put that in a theater, then I said, wow, this just is incredible. This intervention means nothing. And so I started using this more in my practice, which is why we wrote our second book together. And just explaining to patients, all these things I told you were absolutely necessary. I mean, you decide. But these are the actual numbers, and I found that patients just were just as excited as I was.
So we had a conversation with Dr. Rifkin yesterday. We got to see you, and you told us the most important thing to ask is percent of what?
Percent of what?
Percent of what? And to your point, if it's 25% of 1,000, is that really delivering the value back? That it sounds like an impressive number until you put it in context.
Yeah, if your risk of getting a certain disease is 1 out of 1,000,
right,
and then a drug comes out and say we're going to reduce that by 25%, now your risk of the disease is 3/4 out of 1,000.
Right.
So again, they will never show you those numbers because it's not in their benefit to do that.
Right.
But for patients to make informed decisions, they need that number.
Yes, and while motives are always suspect, the famous philosopher said that, not me. The fact is that it's ironic that pharmaceutical companies always use relative values, and so the relative values make the benefits seem greater than they are.
Right.
And the newspapers like that type of headline, so they repeat the headline, and it just is a circular process.
Right.
So we're trying to break that process, and we're trying to demonstrate why what we're doing is far more useful to patients, and it uses a statistical metric that is generally accepted by those who are interested and involved in shared decision making.
Right, which hopefully more and more health plans, more providers, everyone should be really embracing this idea of shared decision making. As you said, we talk the talk, but what's really moving the needle in giving those people, giving our members and patients a tool that they can relate to that helps them make that decision. So
what I've found to be amazing is you hear all the talk up in Congress about how to save money in the healthcare system. The way I've found that money is saved is my patients make good decisions. It comes from the bottom. When patients are allowed to make good decisions, and even in shared decision making, there is no stipulation that you can't use relative numbers. So certain doctors in my community will still use those relative numbers, but that's not really shared decision making.
Right.
That's deceptive decision making.
Right.
And so it's important when we do use shared decision making, patients are true partners in that, and they understand their actual risk and benefits. And under no circumstances would Eric and I say they shouldn't get a certain intervention or procedure, but it's really important that they make that decision themselves, using numbers that relate to reality.
So it sounds to me, and again, you know, what I so enjoyed, I watched these gentlemen gave a presentation not too long ago at University of Virginia, an hour-long presentation. I'm going to make sure I share that link out. You really are, you know, you're making things relatable, but you know, it's just so critical that we're putting it in terms that the average individual can take, but I think it also benefits the clinician. You know, the relationship that you have with your patient is paramount, and by providing such a transparent sharing of information, you're kind of leveling the playing field a little bit, and you know, there to guide, but not necessarily to dictate what that care might be.
We just made a presentation at this AHIP event, and Andy was talking to me about another presentation he has to make, and I said, why don't you title it 20% of what? And he thought it was a good idea, and it really is a good idea, because people should begin to understand that just because a number is thrown out there doesn't mean it relates to anything that they can relate to. Yes.
Well, I have one more little vignette that I think Dr. Rifkin, you had a personal experience, and you published an article. Was it in JAMA?
Correct.
It was called A Grateful But Not Passive Patient. And how many people can relate to that title? You write of your personal hospital experience after suffering a heart attack, which fortunately you were healthy, and Dr. Rifkin, you helped with that. Once stabilized, I want to quote something that you wrote. You state, once stabilized, my physicians consistently pushed for aggressive treatment with little or no attention to the trade-off or how I might feel about them. Not once did they elicit my preference. I was simply told what to do. How can we change this mindset? Is this decision tool a step in the right direction? Obviously, but what more can we do to make sure that no one feels that way?
Well, I think we have to get to the right audience to push it. And I don't believe physicians are that audience. I think that patients need to understand, and I think they are understanding because of costs and other issues, that there's a limit to what they can spend or want to spend, and that there are other ways to understand benefits and risks. And those ways directly relate to how risk averse they are, what they're willing to do and what they're not willing to do, what their preferences are, what their values are. And that's what the decision should be made on. And when I was in the hospital, it was a terrifying experience. But since I knew a little more than the average person, I had written these books, I could push back.
Yes.
And it was a strain, but I pushed back. And in fact, I would call Andy 2 or 3 times a day and say, look, this is what I said. Does that seem to make sense to you? And he generally said, yeah, it does. So I feel I've gone through life feeling if I can do something, somebody else can do it. And this process has empowered me to make my own decisions and get the right information. And it seems to me that if patients and health insurance companies and groups that are trying to help patients get well for not spending a fortune, that's the focus of where this next effort should be. And I think it will result in shared decision making, and everybody will benefit. And doctors will come on grudgingly, but they'll be happy they came on.
I think doctors that, as a doctor who uses this technique, I've embraced it, and my relationship with my patients is that much better.
I believe so.
One huge barrier to this is, it's a word that sounds great, but it's called quality. And insurance companies now, starting with Medicare, are forcing us as doctors to follow quality guidelines. And these guidelines, none of them have us talk to patients. In fact, if we talk to patients, they may not do the guidelines that we're supposed to do. Right. If I tell them about a cholesterol medicine and they decide not to take it, I fail the quality guideline. So it would be a great step forward if true quality guidelines were shared decision making. If in fact doctors were implored to speak with their patients using numbers that the patients understood, techniques like ours that the patients understood, so everyone knows that the patient was involved in care. And yeah, that's the biggest problem I see right now. And someone even in our talk asked that. They say, your technique's great, but I'm in a position as a doctor where if I did this, I'll be dinged. Right. And he was absolutely right. And so we do value insurance companies as a possible means of getting this out to people. Whether they give their patients, their customers, information, and they say, look, we're not telling you what to do, but here's some information when you go to talk to a doctor. But even beyond that, if they reward doctors who have conversations
Right.
rather than doctors who just follow protocols.
Right.
That would move us a long way further than a lot of the reforms that are being talked about now.
Well, gentlemen, I think that the solution that you offer, the conversations that you're sparking, hopefully a lot of the audience members today are leaving with this call to action in mind, that these are the kind of conversations we need to have and the changes to make place, and look at how much we'll benefit from it.
Thank you so much.
Oh,
great.
We're delighted to have you here in the GuideWell Insights Lounge. So again, Dr. Lazarus, Dr. Rivkin, best to you. I will make sure that we share out that link for our audience on your talk so that they can hear more about this wonderful decision tool. So,
Great.
all right, this is Kate Warnock signing off for just a moment. We're going to be up next with another interview. Please keep watching. Hi everyone, welcome back here to the GuideWell Insights Lounge. This is Kate Warnock coming to you live from the 2017 AHIP Institute and Expo. Delighted to have our next guest with us, Donna Green. Donna, welcome to the interview.
Thank you.
Donna is the CEO of Grand Aids USA and International, correct?
Correct.
Okay, all right. Donna, tell us how Grand Aids is personalizing care management for people with chronic diseases.
Well, we do it in several ways. Number one, the Grand Aid is in the home with connectivity to their nurse supervisor back at where the nurse supervisor works.
Okay.
So they can connect via FaceTime, Skype, Zoom, some simple video with the patient with the nurse for discussions about anything the patient is uncomfortable with, has questions about. The Grand Aid is in the home, noticing things, helping the patients get their lives organized.
Right.
And by doing that, what we can do that, say, home health really can't, is we can focus on the patient and that patient's needs instead of that patient's chronic condition. So we're not bound to just heart failure. We can look at the hole in the floor, the asthma in addition to the heart failure, and the needs and the socioeconomic needs of that family as well as the medical needs.
So Donna, I have to, so you're really addressing social determinants of health. You're
Yes.
going into the home and you're understanding the whole environment that this patient is operating in, not just, as you said, the one clinical factor that might have been the cause for you to be assigned to them.
That's right. Yep.
Right.
And we don't have limited, restricted number of visits in the home either. So we can, and we work real closely with home health so that we both can augment each other's services and have someone in the home more days than not.
So Donna, tell me about the kind of individual that you hire to be a Grand Aid. What are you looking for? What's the skill sets?
Our Grand Aids can be anyone that's not a licensed professional in healthcare.
Okay.
We typically recommend that it is a certified nursing assistant, and the reason for that is CNAs love to work with patients. They have a unique characteristic in being able to relate to people in a respectful yet professional
Right.
way, but not so professional that the patient feels like they have to put on the right show.
Understood.
And, yeah,
they can be
it's
themselves.
They are.
Yes.
That's exactly right.
Yes.
And so we look for someone that's very kind, caring, kind of like a grandmother. That's why we're Grand Aids.
Yes.
To have those characteristics: tough love. I love you. I care about you. I'm here for you.
Right.
Kind of. And it's amazing how that works.
Boy.
There's a synergy with the patient, the caregiver, and that CNA, the Grand Aid, where they really bond. I noticed I was fortunate enough to be able to go on a home visit a couple of days ago this week with one of the Grand Aids, and it was a new patient, and it was very refreshing for me to see how quickly the spouse of the patient and the Grand Aid bonded, and the spouse was able to say the things they wanted to say.
Boy.
And have someone listen to them.
So Donna, it's as much about the caregiver and the families as it is about the individual patient, isn't it?
That's right.
Yeah.
If the caregiver is not okay,
Yeah.
they can't take care of the patient.
Right.
So.
Right. Oh my gosh, such a wonderful solution. I have another question for you. Let's hear about more. Do you see more in-home health solutions being developed? Are we going back in time to the Marcus Welby kind of care to really advance population and disease management?
I think we are, for
Yeah.
a lot of reasons. People are more comfortable at home. If they can be cared for at home when they're sick, they can certainly be cared for at home when they're not sick. They can care for themselves.
Right.
Know what the environment is and how to adapt that patient's care plan or treatments to their environment.
Right.
The other thing too is with technology, and we're also we're learning that people don't have to be an RN or an NP or an MD to do a lot of things in healthcare.
Right. Right.
And there's enough task for all of us.
Absolutely.
Yeah.
So I mean, I think what you're speaking to, or there's a lot of burden in the healthcare system. We've heard about yes, and how much of it is unsustainable. So you're identifying maybe an underutilized resource to do some really heavy lifting that really can change the outcome of a patient's life.
Oh, it sure can.
Yes.
That's exactly right.
Yeah.
Well, you just look at the number of people in hospitals that come down with some of these horrible bacterial infections.
Sure.
Just because they're hospitalized.
Right.
If we could just eliminate that.
Oh my gosh, I think you're onto something. So, all right, Donna, a couple more questions for you. I'd love to ask. So, how can we ensure the maximum number of people benefit from receiving care outside the clinic setting?
Well, I hate to say this, but the fact is, funding.
Yeah.
There's so little funding for care in the community and care in the home that it takes a lot. Like most of the programs that Grandaids that we do are sponsored and paid for by hospitals, so that the patients of the hospital's care is better in the home.
Right.
Therefore, help them to continue to heal.
Right.
And
right.
that's a cost to the hospitals.
Right.
So between the insurance companies and the funding sources, and Medicare and Medicaid and our private insurers, that's, we're going to have to turn that way for some reimbursement.
And Donna, I know that's why you're here at AHIP, is to help advance that conversation.
That's
and I know
right.
that our viewers are hearing this and processing it. It certainly makes a lot of sense to me. So I know there's a big change that will have to happen. But I have one more question before we let you go. In researching your background, I see that you began life in your career as a nurse. And
Yes.
I know...
And I'm still a nurse.
And you still are.
Yes.
That's fantastic.
I'll always be a nurse.
So, place in our hearts for nursing professionals. I wonder if you have any advice for nurses who are really looking to take more of a leadership position in the health industry. What can you tell them?
Get involved.
Okay.
Get involved in, if you're working in a hospital, get involved in as many committees as possible within the hospital, because if you do that, you'll find your passion. You will find your passion and be able to work in that direction.
And look for wonderful mentors like yourself. I would imagine that you're there to help foster.
None of us would ever make it without a great mentor.
Right.
Yeah.
Right.
Elsie.
I'm sure Elsie knows. She just got a little shout out. Well, Donna, thank you so much for sharing your time with us here at the GuideWell Insights Lounge, and hopefully we'll get to see you again.
I hope so too.
I'd love to. So, everyone, this is Kate Warnock. I know we're going to be up with another interview. Please keep watching us. everyone, and we're back here at the GuideWell Insights Lounge. This is Kate Warnock coming to you live on location at the 2017 AHIP Institute and Expo. We have a repeat guest, one of my favorites, Helen Leese. Helen,
thank you.
Welcome back.
Hi, Kate. Thank you.
So great to see you. So Helen, you are a partner with the Health and Life Sciences at Oliver Wyman.
That's right.
All right. So you have a great topic that you're going to be speaking here at AHIP. Have you had your session, or you're going to
This afternoon.
Terrific. So this is a little preview for everybody. You're going to be talking about Net Promoter Score. Net Promoter Score in the health industry. Can you tell us why should be more to break it down for us and tell us why more plans should be using Net Promoter Score?
Sure. So Net Promoter Score is simply a measure of how many consumers are promoting your product or offering and how many are detracting from it, right? And obviously you want that ratio to be high.
Right.
You want more people promoting it. And we think that's important. And for the health industry that has gone from being a B2B, B2B2C, increasingly B2C, we think it's important to kind of keep the consumer in mind as you're designing products and services. But we don't think that NPS goes far enough. So we think what's really important is to also build and measure the emotional engagement that you have with your consumers and that connection. So when you ask your consumers, do you love this brand? Do you trust this brand? Do you depend on this brand? And they give you a resounding yes, then you know you've got the holy grail of that emotional connection. And we think that is really important to driving magnetic offerings so that they keep coming back for more.
Okay, so I think your average health plan is probably a little reluctant to maybe see the results of those kinds of questions. Let's talk maybe methodology first.
Sure.
What's the right way to go about in getting that kind of information, and who should be seeing it?
I'm glad you asked. So it starts with a really deep understanding of your consumers, and not just, I know consumers are frustrated with healthcare, I know that I need to solve these issues, but getting pretty granular about segments. So we just are publishing today some research that we did with the Fortune Knowledge Group. It was a survey we ran last fall, and what we found is when you say to people, are you satisfied with healthcare, they kind of shrug and say, yeah, it's fine, status quo. But when you start to probe and ask, what are your top concerns? What are you most worried about? Pretty quickly you hear about health insurance cost, health care cost, and access and quality.
Sure.
So when you dig into that even deeper and you talk to millennials versus boomers, it's really interesting. I think the millennials are a very exciting segment to me because they're driving a lot of the demand for new products and services. They're asking questions. They're saying, is there a service that can help me with this? Is there a technology that'll do this better for me?
Right.
But what's interesting is they're not just interested in technology. They're looking for things, especially millennials who've been just diagnosed with a chronic disease, for example. They're looking for financial navigators because they want to figure out, how do I figure out how to pay for these healthcare costs? They're looking for patient advocates. They're looking for communities of patients like them who've been on a similar journey, which is where you see this proliferation of the Facebook-like chronic disease communities. And that's not what we saw with boomers at all, right? Boomers are much more traditional. I don't want to say they're resigned to the healthcare system, but I think they're more experienced with it, so they kind of know how to navigate it, and they don't think to ask for new services. So they'll say, no, I don't need anything. But then when you ask a boomer, well, what are you worried about? And how do you think your healthcare will evolve in the future? They'll say, well, I think my healthcare is going to get worse. They don't expect it to get better.
Yeah.
And they'll say, I'm worried about things like loss of, and regardless of whether or not they think they're going to get sicker, I'm worried about loss of mobility. I'm worried about loss of strength. I'm worried about my lifestyle just generally worsening and declining.
Sure.
So I think it gets really interesting when you think about what's the offering that a health plan can create for a millennial versus what's the offering that you would create for a boomer. Completely different underlying needs and worries and concerns.
Absolutely, but what you're talking about is the opportunity, if the health plans really understand what those wants are, to create that magnetic offering that you were just suggesting. So it's really, maybe a tough question to ask, but what you get in return looks like it's a whole new world.
Right, and when you look at companies who've built that emotional connection and they have that magnetism, inside of healthcare or outside, you see they're outperforming in terms of stock price, right? Look at Amazon, look at Apple, look at USAA. You see they have not just higher customer satisfaction, but people are more likely to adhere to the care plan. They're more likely to renew with that insurer, and it's a higher lifetime value of the customer.
Right. It makes so much sense. Let's take it up a little bit here for your next question.
Okay.
So, we know that consumers are far more savvier with their healthcare dollar, and look at the examples that you just gave us.
Yep.
what are the essentials that the health industry must deliver on?
Right. So I think this is a really interesting space to watch, because now that consumers are spending for themselves, right, they have shouldered more of the cost burden,
right,
and they're not spending somebody else's healthcare dollars, we're seeing them make different choices, right? And we're already seeing it now in things like higher patient abandonment rates for prescriptions. They're delaying refill times. I mean, with my own child, she has a tree nut allergy, and my husband and I had a discussion about the EpiPen is now $600. Yep. What do we want to do about that? That's an interesting conversation to have for something that we hopefully won't use, and will expire, and we'll have to have the same conversation a year from now.
Right.
So I think it goes back to that, understanding the consumer segments and who's going to be making what choices and why, and how can you craft something for them that really gets at their personal needs around affordability, access, convenience.
Right. You know, everything that you're speaking to, Helen, it just sounds like health plans, they can become so innovative, you know, and really create, you know, a whole new platform, a whole new product offering that maybe a decade ago wouldn't even have been considered. And as you said, by segment, you know, it's a really exciting thing. So just starting with this whole concept of Net Promoter Score, as you said, you have to do so much more.
That's right.
Yeah,
that's right.
All right, one more question for you, and this is a little bit departure. You know, but the Lancet, you know, published out of Britain, published this series, this 5-article series, all around health equity and equality in the United States health system. So it put into high relief the health's connection to income. You know, there is just such a strong correlation. So how can we ensure all benefit from this patient-centered care, not just those who can afford it?
Right.
It's a big question.
It's a real conundrum, and I serve executives from payer organizations, provider organizations, and pharmaceutical companies. And I'm increasingly hearing in my travels executives asking the question of, this income disparity is a real problem in our country, and how can we help make sure that anyone who needs it can access the healthcare system and get the quality care they need. And you know, we say we want good schools, we say we want better roads, and it all comes down to, are we willing to pay for it? And I think, you know, what we've seen to date is we're not willing to invest as much as we need to on chronic disease prevention. We're not willing to invest as much as we need to on ensuring that vulnerable populations have access to quality care. And in some research that we did last year with the Robert Wood Johnson Foundation with consumers, we found that what I'll call vulnerable populations, so consumers who are either low income or low literacy, maybe they're on Medicaid, maybe English is not their first language, they really struggle not just with accessing care, but with accessing information about care. So how do I figure out what this diagnosis means? How do I decide what treatment path makes sense? How do I understand what it's all going to cost for me? Is very overwhelming for them in particular. And then once they actually are in a care setting, we found that vulnerable patients who don't feel respected by their providers are more likely to just not adhere to the care plan, not come back. And that has real economic consequences for all of us, right?
Oliver Wyman published a paper about that, and I remember reading it, and just how it was such an eye-opener. That simple thing of respect needs to be a two-way street, and if it's not returned, you lose that patient. And how simple it is to, you know, create that dialogue when, you know, we've had other guests here in the Insights Lounge, Helen, and just talking about we're not asking doctors to have conversations with their patients. We're not incentivizing conversations. We're incentivizing care and quality, you know, the things that, you know, we're doing our best, but there's so much room for improvement, isn't there?
There certainly is.
Yeah. Well, I think we could just talk forever.
I know, I do too.
About this, and you're such an expert in so many different areas. So we're delighted to have you here, Helen, and look forward to having you back again.
Thank you.
In the Insights Lounge. So thanks for joining us.
My pleasure. Thank you.
All right, my name's Kate Warnock. We're going to be taking a short break. We're going to be up with another guest in just a little while. Keep watching. If you're
and you look at the
if you're
and you look
I'm